So next is Dr. Savio Pereira, who will be presenting the keynote address with the topic cataract surgery as refractive surgery, optimizing outcomes. Back to the basics. Dr. Savio did his MBBS from KEM Hospital, Mumbai, MS from INHS Ashwini, which is in the Navy. So he's actually a Lieutenant Commander. Yeah. But he did his DNB and long-term FACO, refractive fellowship from Netradama, Super Specialty Eye Hospital, Bangalore, where he holds a position of senior consultant at present. So, yeah.
Thank you for the very warm welcome. Thank you, Kerala Ophthalmic Society, for having me here, Dr. Ambika for inviting me. And when we're talking for cataract surgery as a refractive surgery, we have to understand at the end of the day, every person desires to be glasses free. Now, this has been not now, it's been from ancient time. The Chinese used to keep sandbags on their eyes, so when you would sleep and get up in the morning, you would actually be, the myopia would be cured. Even Purkinje tried the same thing, the famous Purkinje images. And if you look back in time, right from the 1800s, there were a lot of these ads coming out where people would try to just, another form of orthokeratology, where to try to have mallets, something pressing on the cornea, and give you some amount of glasses-free vision. Now, what is happening nowadays is you have patients who are post-LASIK, post-refractive surgery, post-phakic IOLs, coming with cataract, and they want to be glasses-free again. And that expectation is something which is a huge, huge weight on the surgeon and on the entire system. So when you talk about biometry for such patients, or any of your patients, be it immersion, be it contact, be it your optical, be it ST, OCT, the axial length is never a problem. In high myopes or hypermetropes, the axial lengths are pretty accurate in all of these. Whenever you get any study and something is controversial, I just look at two things: the financial interest of the authors and the disclosures. And if it's of the same equipment, I just put that study aside, because it's very easy to exclude all the wheat from the chaff. Now, the main problem is the keratometry, and that is the key in your biometry. And we have to thank Dr. Shimizu et al., who invented the toric IOL way back in 1992, and he presented it in 1994. But what happens when you're doing keratometry, be it the manual, be it the automated or topography, is that each of them work on very different principles. And most of them, since they have a camera in the center or a viewing system in the center, 3 to 3.2 mm of the center cornea is always missed. And that data is extrapolated, and that's the reason why your keratometry goes off in LASIK patients, in other patients, because that's the main part which is treated. So what do we do? Now, we went back ahead and we actually found out what if you don't have the high-end equipment, oh, I have this, I have that. Manual K, for most of the regular cases post-LASIK, give you pretty good accurate keratometric readings. And I'm saying it, there are studies which actually say it. So yes, you can use your toric lenses even in irregular astigmatism, but they have to be very specific indications. Always look for regular astigmatism. And as Dr. Ambika said, that you have to be very careful, and you can give the patient optimized, customized toric IOLs in very high powers which are not available. Now, one of the few things I want to mention over here is if you have optical biometers, they measure it either in 6 zones, 8 zones, and if the astigmatic axis is between these, be careful, the data is again extrapolated. And that is where manual K scores over, because you can rotate it and get the axis much more accurate. So if you have a Bausch & Lomb manual K rusting somewhere in your OPD, use it. It does help a lot. And whenever we do have any doubts, we go back to the manual K and just verify. It gives you a little bit better good night's sleep the next day. So regarding the point of whether you should use higher lenses or lower lenses, especially since you get gradations of plus 0.5, a very simple rule I would say is always overcorrect the astigmatism in against the rule. So add for against the rule. The one other thing, just forget it. Just remember this one thing. Add, so if you're getting between powers, you're not sure which one to go for a little higher power if it is against the rule. So remember plus, add against the rule. That's how I remember it. It's exactly opposite for with the rule. Regarding surgically induced astigmatism, there have been lots of studies, lots of papers. Everybody claims to have the lowest surgically induced astigmatism. And the real fact is, if anything is less than 2.8, 2.2 incisions, or 2.8 itself, you don't induce much astigmatism at all. But the real fact of matter is, I would say, a temporal incision is one of the best things to do. And if you're doing superior incisions, nothing against you, just switch over to temporal, do a pre-op and post-op K, and you will see the amount of astigmatism you induce is much, much lesser. So try this out. Regarding calculators, and you don't need to have expensive biometry. Most of the biometrists these days, they come up with licenses to use the online calculators, which is actually freely available. You just have to know which website to go to. So in patients who are post-LASIK, you have LVC, that is the laser vision correction mode, and you can actually put in all these data, what was the pre-op refraction, what was the topography if it's available, and you will get the laser power correction, and you will have a much better biometry. Now this is free of cost. Now regarding toric IOLs, there's a lot of hue and cry. You know, they had these markerless systems coming up saying, oh, they had these smudged images of people having all blue eyes post-marking. Marking, if done incorrectly, can have a plus or minus 10 degrees. So the very simple thing is just do a good slit lamp marking. The main problem with slit lamp marking is that you do it yourself, take it up as the first case the moment you scrub inside. And the key is exactly bang across, bisect the pupil. Do it nicely, make a fine slit. If you're not sure about your mark, so you're using an old marker, take a simple 26 gauge needle and indent the epithelium on either side. You do get marks which stay in at the end of surgery also. This is one of the tricks you can use. If you have a fresh marker, nothing like it. Now, I'm just coming to high myopia and hyperopia. Now, what happens in high myopia, you should understand, is that first of all, your axial length can be slightly off. Because of the posterior staphyloma, sometimes they can't fixate properly because they have macular scars. You can indent the cornea a bit, and most of the formulas, if your axial length is above 27, there's a fudge factor. It's not very accurate. The same thing happens with hyperopia. The ACD is effective, the ELP changes, you have a shallow anterior chamber, so be a little careful in these types. So I'll just give you a few things that it's there everywhere, all this. We use Barrett Universal too. It's a safe formula, you get most of the things right, and at the same time, what happens is it's free of cost. So I'm just going to discuss a few cases over here. We had this young patient, 47-year-old. Patient is post-LASIK, post-phakic IOL, done 18 years back, and comes over here for a cataract surgery and says, now, what to do? I want you to just look at the IOL powers over here, and you can see that I will put each and every formula over here, right from the ray tracing formula right down, up to Barrett Universal 2, and you can see the variation in formulas that are there. Now, what we did was, one more thing I want to see is, you can see by just putting untreated and by putting LASIK in the LVC mode, you see the power changes from 0 to +2 straight away. So this is something which I was telling you. If you go to the online and say post laser vision correction, the extrapolated data changes, and you can see here, 33.27, 33.28, the axial length is not your problem. It's the keratometry that gives you the problem. And that itself changes. The same lenses, 0 to +2. On a word of advice, always, always in all your patients who are highly myopic, target -2 straight away. Even if you make a mistake, you are going to make the patient myopic, and he's always been myopic, he will thank you. Now, one of the things I usually do is check for dominance. And do the eye, which is for near first, the non-dominant eye. Target a little bit more of myopia. That gives you how the lens is going to behave in the eye. And that will give you a better correction. So even if you got a -1.5, the patient is still happy. These are very high myopes. You can see the axial lengths. Now, another case of high myopia, this was a patient where the patient was having a refraction of -28 and -24. This is huge. And we couldn't put never went for a ICL because the ACD was very, very shallow. So we went ahead, and you can see the axial length. You can see everything is done. And the lens selected is minus 5.5 by the IOL master, but we went ahead and put minus 3. And this is what I'm telling you. Your target refraction, always go ahead and keep it around minus 2 diopters more. Or you can just simply go ahead with your target refraction, and instead of keeping it 0 over here, go ahead and keep it minus 2. This is very easy, and it's putting simple monofocal lenses and trying to make your patient glasses free. We did it for the other eye also, and you can see it's showing minus 3. We went ahead and put a minus 1 lens. Go more towards the plus. That is the key. Now, this is one of the shorter eyes which we did. This was actually a young patient, 19-year-old, who had plus 12, 12.25 and 12.75 in the other eye. Now, when you're talking about refractive lens exchange, I'm almost done. This is my last slide. This was high, and you see the IOL power, plus 46, plus 47. These were patients, you can't treat them anyhow, be it ICL, be it LASIK, nothing. Patient had such thick glasses, we went ahead, did a refractive lens exchange, put in a simple monofocal lens. You can see the variations from formulas, from SRKT to Barrett Universal 2, 42 diopters to 46 diopters. So be careful. Do with different formulas, and then you can go in for an average. Tell the patient you will have to still wear glasses. We put in plus 46, plus 47 in either eye. In the end, you can see that the patient developed 26 by 18, and the patient was amblyopic before, but this is what I'm trying to tell you, that you can give good results to these patients and give them an option of going in for even a refractive lens exchange, because having a plus 12 diopter glasses is not easy. You know the aberrations. So just to summarize, this is my last slide. Think of customization of IOL power, what Dr. Ambika said. Monovision gives you excellent outcomes in high myopes, hyperopes also. Counsel your patients. Talk to them. Tell them that there is a margin of error even in the best surgical hands, and also that you need to be prepared to wear glasses. Check refraction, do one eye, plan the other eye, and always under-promise and over-deliver. Thank you very much. Thank you for having me here.
Thank you, Dr. Savio. Thank you to all the speakers.